Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and to get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Tom Zaubler. He's a psychiatrist and a physician executive. Today's KevinMD article is titled Maximizing Care Amidst Provider Shortages, the Power of Measurement-Based Care. Tom, welcome to the show.
Thank you very much. Pleasure to be here, Kevin.
So we'll get into the article in a little bit. First off, briefly share your story and journey.
Yes, Kevin. I'm Tom Zaubler. I'm a psychiatrist, chief medical officer at Neuroflow. Neuroflow is a technology company focused on creating a digital infrastructure to improve identification, triage, and access to behavioral health care across a multitude of clinical settings and a range of acuity. We work with payers, providers, health systems. Prior to that, I was a department chair for 21 years and have been immersed in the world of integrating psychiatry and behavioral health for about 3 decades now. So measurement-based care and improving access to behavioral health care has been a lifelong mission of mine.
So talk about that transition from more of a clinical role into the CEO role. So talk about a little bit about that transition.
CMO. So it was let me just share with you how I got to there in the first place. So I was spending a lot of time seeding these population-focused, measurement-based treatment to target models of care, integrating psychiatry and behavioral health into medical settings for decades, and recognized that there were real limits in terms of what one can do without technology. So I was looking for a technology partner to deploy and scale these models of care. And in the course of doing that, came across the company where I currently work and was taken with the platform and realized that I could really impact a much larger population of individuals, literally millions of individuals, as opposed to tens of thousands that I was doing before, and was very excited by that. So, to me, it's a way of really looking at how can we improve access on a much, much larger scale to behavioral health treatment, surface underlying illness. So it's been very exciting. It's been an eye-opening experience for me, coming from the world of sort of traditional healthcare in a large health system, but exciting, and things move much more quickly in industry, as you are aware, I'm sure, than often in academic environments or large health systems.
All right, so let's talk about how you move the needle. The KevinMD article is titled Maximizing Care Amidst Provider Shortages, the Power of Measurement-Based Care. Tell us how your article came together.
So let me give you a little bit of background just for a minute, just talking about some of these statistics. So we know that psychiatric illness, behavioral health disorders are incredibly prevalent. About 20% of the population have an underlying psychiatric disorder, about 58 million people. We know that pre-COVID, about 1 in 10 individuals described having symptoms of anxiety and depression. Post-COVID, that number has shot up. It's about 40% of the population. We see that the rate of suicides has gone up significantly. Last year, it was 49,000. It just keeps on growing. 111,000 overdose deaths last year. What we see with these deaths of despair is that the average lifespan for the first time since the 1920s in the United States has gone down from 79 years to 76 years. Again, a lot of that has to do with these deaths of despair. Psychiatric illness, leading cause of disability in the world, rarely occurs in isolation. So depression, as an example, co-occurs with stroke and diabetes and heart disease. You can't have good physical health without having mental health. And we know that psychiatric illness drives the cost of care up significantly. So those with chronic medical conditions and co-occurring psych illness cost 2 to 3 or even 6 times more than those with the chronic medical conditions without the underlying psych illness. So it's really prevalent. And then we have these barriers, these problems with access to care. So, there's stigma that's still an issue, getting better, but we have major workforce challenges. There are just not enough psychiatrists. 55% of all counties in the United States report having literally no psychiatrists. 77% of counties report having a significant shortage of psychiatrists. State of Maine, just as an example, had a 50% drop in the number of psychiatrists from 2015 to 2020. Wait times can be as long as 18 months. I mean, that's just not acceptable. And like myself, 70% of psychiatrists are 50 and older. So this is just going to get more pronounced. We know that patients with underlying psychiatric illness present with their problems in medical settings. They don't present in behavioral health settings. I mean, the irony is that 95% of behavioral providers work in these either primarily or exclusively siloed behavioral settings. So we really need to think about ways that we can integrate care, which is a lot of what the article was talking about, and identifying those individuals who are the 20% of individuals who account for 80% of all healthcare costs, because the vast majority of those individuals have underlying psychiatric illness that drives that increased utilization. And so the reality is we have this situation that 60% of people with psychiatric illness in this country, 90% of people with substance use receive no care whatsoever for their underlying mental or substance use disorders. Imagine if that were cancer or diabetes or heart disease. So the reason that we submitted the article is it really speaks to the importance of surfacing underlying psychiatric illness, doing that in a methodical way with screenings and measurement-based care, which I can touch on in a little bit, and doing that across a multitude of settings, not just behavioral health settings, but medical settings as well. So that's a little bit, and I'll go into some of the solutions, the population focus and measurement guided models of care and the technology, but that's a little bit of the background in terms of why we feel that it's really important to address these issues and to bring this measurement-based objective type of assessment to much larger populations.
No, absolutely. I think what you say rings true. I'm a primary care internal medicine physician myself, and really just that lack of behavioral health care has only been exponentially worse during COVID. So in terms of the model that you propose, tell us more about that as a solution.
So there are these population-focused measurement-guided models of care. So collaborative care is one model that is the most well-studied, over 90 randomized control trials showing its efficacy. That's something that's been around since the 1990s. I had the good fortune of actually being at the University of Washington when this was really first being created. It's a tale of two cities. On the one hand, it's a wonderful model, but the uptake has been not great. I mean, only about 20-30% of primary care practices have any sort of meaningful behavioral integration. So there's a lot of work that needs to be done. These models of care entail a team with a primary care doc, it could also be an oncologist, it could be a GI doc, it could be a cardiologist, a behavioral health clinician integrated in the practice, and then a psychiatrist. And that psychiatrist is actually not seeing patients directly. They're providing caseload consultation to the clinician and clinical decision support for the primary care physician or oncologist or whomever it is to make sure that a large caseload of patients can be seen. So you see a psychiatrist who's consulting just a few hours a week covering literally thousands of lives, whereas if they were seeing the patients directly, they would not see so many lives. And a critical component of these models of care is universal screening with standardized scales like the PHQ-9 for depression and the GAD-7 for anxiety. And the reason this is so important is that patients don't get better if you're not tracking those outcomes. We know in primary care, and Kevin, I'll defer to you on this, but in primary care, first of all, most depression and anxiety is missed. And when it is detected, only about 20% of patients get better because the follow-up is hard when you have appointments that are spread out 3-6 months apart. Patients go off antidepressants, the dose of the antidepressant isn't adjusted, they're not getting the psychotherapeutic support that they need. So these models of care are really critical, and providing objective assessments to see how patients are doing over time to make sure that treatment can be adjusted if patients are not getting better. It's like if a patient has COPD, we're getting pulmonary function tests. If a patient has diabetes, we're checking glucose levels or hemoglobin A1Cs. There are objective measures to see how patients are doing. In behavioral health, sadly, 80% of the time, behavioral clinicians are not practicing measurement-based care. And that really creates a lot of subjectivity and an impressionistic sense that you get in the snapshot that you're with a patient. So that measurement-based care is really critical to ensure that you're surfacing in large populations who has psychiatric illness, and that you're ensuring that patients are getting the right care at the right time, and that you're triaging patients to that right care. Can talk with you about some of the technology that makes this possible as well. But that's that model of care. Or there are multiple models of behavioral integration. Collaborative care is the one that is best studied, but there are many that are immensely helpful and effective.
So before getting to some of the technological solutions of implementing that, give us your ideal scenario in a primary care setting. So if I were to see a patient, for instance, in my exam room, walk us through a hypothetical scenario that would meet your ideal.
So the ideal is that, and so I may touch a little bit on technology, if I may, on this question. The ideal is that in that primary care practice, that every patient in the practice is being screened for underlying psychiatric illness. So it's not a question of when the patient comes into the practice that they're getting a pen and paper assessment and you're doing it right then and there. You're doing it with everyone. And so if they're coming in for an annual wellness visit or any other visit, you already have some information about how they're doing. And you can say to that individual, we noticed that you scored at this level on these scales for depression, anxiety, and we provide holistic care. We really believe in looking at the whole person, and we want to introduce you to this individual who works in our practice. This is a behavioral health clinician, and we feel that that's really important to provide whole person care. And because of some of the way that you answered these questions on these scales that we sent to you in your home through our technology, we would like to engage you on an ongoing basis with technology, but also with this individual, this clinician in our office who can help you both therapeutically as well as doing care coordination if there are any outside providers that we need to contact and so on, and ensure that you get the care that you need. And that individual then is going to be tracked with assessments that can be done remotely through digital tools. And with that behavioral health clinician, what we call a behavioral health care manager in a collaborative care context, will be meeting with that individual periodically as needed. They might be very brief meetings by phone. Some of them, it could be in person, it could be virtual. And what you see is that model of care surfaces a lot more underlying depression and anxiety and PTSD and bipolar disorder. There are studies now looking at a range of psychiatric problems, and patients get better. They really get better.
So you mentioned some technological solutions to screen that patient population. We'll talk more about those options.
So, for decades, I was using pen and paper assessments, using Excel spreadsheets, and it's really, really tough. It's a burden for the physicians, it's a burden for the medical assistants, and it's really hard to do. So technology now has the ability to send these remote assessments via an app that someone can look at on their phone or on a desktop. There are many ways of doing it, and they can complete those assessments in the comfort of their homes. And that's a much more accurate picture. When patients present in medical settings, there's a level of nervousness that can influence how they complete those skills. Sometimes they're reluctant to share things. So what we see is that when you provide these assessments in the comfort of their homes at a time that's convenient, they're not going to feel as rushed, they're not going to feel as pressured. And you're more likely to get an accurate response, and you're more likely to get a response, period. So technology can provide those scales to patients for depression, anxiety, and of course there are a multitude of other scales for different other psychiatric disorders. And then when patients score positively, there can be digital self-management tools, digital cognitive behavioral therapy for depression or anxiety or insomnia or substance use disorder. There can be journeys, galleries, video content to help patients to manage their anxiety and their depression. There can be content there that can be used by a clinician who is working with an individual for their depression and anxiety to provide assignments and homework and so on. A lot of that is driven by AI, so it can be automatic. Some of it can be manually assigned. So there's self-management tools as well as the assessments. And then those assessments occur on an ongoing basis. So it's not just the initial index scores that surface the underlying psychiatric illness. It's the ongoing assessments, as I've said before, to make sure that patients are getting better. And if they're not getting better, there are alerts, there are triggers that can let the primary care doc, the oncologist, the cardiologist know that, the patient is not doing so well and we need to modify treatment. And treatment, therefore, can be modified. So everyone is really operating at the top of their license. And very importantly, if patients are at immediate risk for safety, and this is something that I am really passionate about, it can alert the physician in the practice and everyone else in that practice the risk. And there are mechanisms to respond with caring contacts and human support in the moment for those individuals. And that without sounding melodramatic, can literally save lives. So a lot of ways that technology can be utilized. And there's also, so that's the patient-facing side. There's also the data analytics side where technology can look at claims data, can look at discrete data from medical records and identify patients who are at risk. Identify patients who are at risk not only now, but who are going to be at risk 5 months from now, 6 months from now, 1 year from now. Identifying who is a distressed high utilizing patient and who's going to be a distressed high utilizing patients. There are algorithms of care that exist right now that technology can deploy to determine those predictive analytics, and then provide support for those individuals with rising levels of risk so they don't continue to rise, to preempt them from becoming acutely ill. And then finally, all of that can populate into registries that show how patients are doing, that integrate with EHRs and so on. So the physicians and the behavioral clinicians and the practice can see all of this and make sure that everyone is operating in sync, and again, at the very top of their license as efficiently as possible.
So tell me the typical patient response rate, some patient feedback. Sometimes when patients schedule an appointment with me, they get several texts reminding of the appointment. After the appointment, they get several texts about patient satisfaction scores. And just in general, what's their feedback? Do you worry about just so many different touch points with the patient, so much outreach with the patient that there's a little bit of fatigue there? But in general, what kind of experience do you get when this is implemented?
Yeah, I think that is a concern, right? I mean, I think part of it is the interface that you have digitally with a patient, because if it's a very friendly, inviting, non-clinical digital interface, and even that word is overly clinical, but if you can invite patients to a platform that feels friendly and inviting and engaging with gamification and tokens and redeeming those tokens for cups of coffee and all that sort of thing, it can make a real difference. And it starts to feel a little bit like a game, and it's interesting. And then if you add value because you're providing support in the moment, let's say it's someone who isn't scoring positively for depression and anxiety, they're having difficulty with insomnia. And let's say there's digital content for managing that insomnia. That's useful. If someone is feeling lonely and they want to look at ways to relationship build, if they need mindfulness meditation. So there's wonderful content out there that can be digitally delivered in a very user-friendly way. So I think it really comes down to what the interface is like, how it gets sent. It's really important that physicians champion the technology. Physicians are really burned out. We know that there's a bias in some ways against technology because EHRs are a source of burnout in some ways. So it's really reframing the way we think about technology, and it's a way of extending the work that goes on in the practice into the patient's home. And what we see is that engagement rates 60%, and that you remain highly engaged over time. So we're seeing individuals that were not getting treatment suddenly getting treatment, getting better. And then what happens is that the tinnitus, the back pain, the headache, the things that individuals present with in primary care that are really driven by underlying psychiatric illness, they start to dissipate, and the calls go down, the administrative burden goes down, physician satisfaction goes way up. So it becomes a win-win. So something that you have to be sensitive to with technology. I don't believe that technology alone is the answer. I think it's a combination of technology and human beings, high tech, high touch, absolutely critical. But technology is clearly a big part of the picture and a growing part of the picture.
We're talking to Tom Zaubler. He's a psychiatrist and a physician executive. Today's KevinMD article is titled Maximizing Care Amidst Provider Shortages, The Power of Measurement-Based Care. Tom, tell us some of your take-home messages that you want to leave with the KevinMD audience.
So take-home message is, one, recognizing that you can't have, as I said before, you can't have physical health without mental health. It is really incumbent upon everyone in the healthcare ecosystem to recognize that, to come up with mechanisms to surface underlying psychiatric illness and improve access. We have major challenges with workforce. So the message is recognize the importance, recognize the disability, recognize that you can't manage diabetes, you can't manage heart disease, you can't manage a whole range of medical problems without addressing the underlying psychiatric problems. That's one message. I think the second message is there's change management. We recognize that it's really tough, that primary care physicians in particular, oncologists, cardiologists, they're working hard. We can't just expect them to take on these models of care, and that hasn't happened without a lot of support and help. And that's where technology comes in. It makes it seamless. It makes it possible to do these models of care in a way that unburdens the physicians and economizes on their time and creates tremendous efficiency and ensures that everyone operates at the top of their license. And it provides the ability to extend the work that goes on in the practice into the patient's homes with those digital self-management tools for patients. So that's another take-home message, that let's look at ways that technology can help to scale and deploy these models of care that are so immensely effective, population-focused, measurement-guided.
Tom, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
My pleasure. Thank you for having me.